Okay, great. Well, with that, Facundo, would you like to make the introductions?
Sure. So this is the first time Dr. Ricardo Terra from Brazil is going to present the case. He joined to us recently, and he's actually in charge of a pretty big thoracic robotic program in Brazil, in Sao Paulo, and really into education of this robotic program in Latin America. So I guess that most of our group will know him because of this. So without further ado, if you want to proceed, Dr. Terra.
Well, first, thank you so much for the invitation and for the opportunity to present this case. It's my pleasure to be here and be part of this group. I think it's very important that we share, knowledge and share our doubts as well. And so I think this is a very good initiative. This case, let me just open it. It is here. Okay. Share screen. Share screen. I hope you can see my screen right now. So I'm professor of thoracic surgery at the University of São Paulo. So these three pictures you see here is the Heart Institute in the left hand, where my office is, and it's the Department of Cardiopulmonology. Then you have the medical school, University of São Paulo Medical School, and São Paulo State Cancer Center, this tall building. It's where I do most of my cases in the public hospital, and Albert Einstein Hospital, where I run the thoracic robotic program in the right-hand side. So this is where I work here in São Paulo. This case was a challenging case. It was a 30 years old female. As many of our cases recently, she had findings during a chest X-ray because of COVID-19. And so as an incidental finding, I'm sure you all saw many cases like this.
Adriana, I think you need to be muted. If you can hear us.
Thank you. And so she had no previous history of smoking and no other relevant comorbidities. And this is her X-ray. As you see, there is this mass in her left side. And this is her CT scan. There was this big mass in her left upper lobe. No other nodules or no other findings in her lungs, as you see in the CT scan. And we couldn't see any enlarged lymph nodes in the mediastinum, the paratracheal nodes, but there were enlarged lymph nodes in her aortopulmonary window, as you see here, and this mass that was involving the left pulmonary artery. So that just for you to see again. Well, this patient, these are the key images, so that you understand better the findings. And so this big mass in her left upper lobe, it was in contact with a fissure, but apparently no invasion, transfissural invasion. And you see in the mediastinum, there were no findings specific in the paratracheal region. However, in her aortopulmonary window, we could see an enlarged lymph node. and also this big mass involving the left pulmonary artery. She had a PET scan. The PET scan showed SUV uptake, FEDG uptake in the mass and also in the hilar lymph nodes. The SUV max were, I can't remember, but it was something around 9. And then we performed a bronchoscopy. In her bronchoscopy, we couldn't see any mass inside the bronchi, but for more vascularized mucosa in her left main bronchus. We also performed in the same procedure an Abbas, and we could see an enlarged lymph node in the paratracheal region and in her left hilar topography, but also a mass, but there was an interposition of the pulmonary artery. As you see here, it wasn't possible for us to biopsy the mass directly because we would have to cross the pulmonary artery. I know that some people do that, but I must say that I don't. And so I biopsied the lymph node, and this was the clinical pathology. As you see, the 11L lymph node was positive. The pathologist said it was a neuroendocrine neoplasm, chromogranin positive, and synaptophysin positive, and the 4L lymph node was negative. I'm not sure why someone ordered a transthoracic biopsy. This was, I think, discussed in our multidisciplinary board because there was some doubts with regards to the real histology of the tumor, and then they confirmed a carcinoid tumor, a low-grade neuroendocrine tumor, and with a clinical stage T3N1. I'm not sure why N2 there. It was N1. And she had a low cardiovascular risk, and her pulmonary function was quite good, as we would expect for a 38 years old woman with no previous history of smoking or any other relevant comorbidities. So I have actually three questions. The first one is maybe we could stop here and discuss a little bit and then move on, or I could finish everything and then we discuss the three questions at the end. What do you think it's better, Facundo?
I think it's a good idea to stop here and maybe poll the audience. It's a great case. Look, I'll start by throwing my 2 cents in there. As I was looking at the scans, I was noting that it was well circumscribed, which to me, it did not look like a non-small cell lung cancer. I was thinking maybe carcinoid, but also maybe sarcoma of some sort. Diagnostically, maybe an angiosarcoma or something, especially because the PA seemed so involved. However, it turned out to be a neuroendocrine tumor. I think you mentioned biopsying through the PA. I'll sometimes do it if I use the 25 gauge needle. That's the smaller needle. It's relatively new. And I think you can go through the PA as long as you have a direct view at it. And you can sometimes change the angle and get lucky and get a window. So I'll usually put a 25, but you got a good result from the hilar lymph node. Yeah. I guess what I would caution is, although you confirmed it, are we sure that it's not a sampling error of the low gradeness of the carcinoid, and could this actually be a more higher grade tumor? It's large. It looks like there might be invasion of the PA, or it could just be obstruction. How comfortable are we that this is indeed a low-grade tumor?
Yeah, that was a good question, and I think this was I wasn't in the discussion in the MDT when this case was presented. I was abroad, but they decided to perform the biopsy just because of what you just said, because they were the oncologists were a little bit concerned about the final the final histology, and it could be other things, and so they weren't very convinced that it could be a neuroendocrine tumor like a carcinoid tumor. But then the final pathology at the transthoracic biopsy confirmed that. But you were right, it's not because it came as a low grade, it is low grade. It could be just a sampling issue, right?
Yes. Could you show us the scan again, Ricardo?
Sure.
And then,
This one?
yes, I think so. Just to me, it looks encased. Is that correct?
Yeah.
Okay, so in the audience, what should our next step be? We have a T3N1 low-grade neuroendocrine tumor biopsied twice in that left hilum. Stella, what do you think?
Excuse me, Abbas. I think that the trunk of the pulmonary artery, left pulmonary artery, is involved.
It looks
I think the possibility maybe is a pneumonectomy. I think in this case I prefer repeat the biopsy by percutaneous biopsy.
It was done, Stella, and it confirmed neuroendocrine carcinoid tumor, low-grade neuroendocrine tumor. So that was the concern also of the medical oncologists, but it was done, and the transthoracic biopsy, percutaneous transthoracic biopsy, was confirmed the neuroendocrine tumor.
Thank you, thank you.
So Stella, you would proceed with surgery at this point?
Yes, I think we don't have any other better option. I will try to explore how is the pulmonary artery in surgery and try to do the best surgery for this patient.
Luis, Dr. Garcia, are you there?
Sure.
Hey,
Abbas, good morning.
Good morning, thank you. Would you consider any neoadjuvant therapy, or would you proceed to surgery? And at surgery, would you attempt a double sleeve for this, or a PA sleeve if necessary, or would you just proceed in this 38-year-old with a large hilar tumor with a pneumonectomy?
I would proceed with surgery. I think that there is no a better option. As Stella said, I think that we should go in a case like this. It's a little similar that the case that I presented the last month with a large neuroendocrine tumor, where you have nothing else to do. It's just proceed to surgery and to try to make an sleeve pulmonary artery resection. I think that that's the better option. It's not easy. It's not easy. It looks very, but we have the chance to go intrapericardial for the control of the PA. So that's a good option to go intrapericardial for this case.
Turn.
Yeah, this is a similar case to the case we were discussing last meeting, and the interesting thing is the opposite side.
Yes.
So that was a very interesting case, Luis, by the way. And with regards to once we go to surgery, would you have any special to deal with the artery? Would you go straight to the intrapericardial artery? What would you do in this case? Of course, we would try to avoid pneumonectomy, but how would you plan it?
I agree with Dr. Garcia Reddy about go directly to the intrapericardial control of the pulmonary artery. And about the neoadjuvant, only it's not confirmed it's going to prognosis. It's also bad for the dissection. It's going to get worse.
Dr. Serna, I think there was some interference, but from what I heard, you'd start the intrapericardium and you would control the PA there, and then you would explore the tumor. Is that correct?
Absolutely correct.
Yes. Yeah. Any other thoughts or tricks? I agree. For my part, I would probably approach this robotically, because I think in my hands I'm better with the robot than open. But of course, it doesn't really matter how you approach it, as long as you think the case through. I agree with placing proximal control on the PA, especially if you're planning to attempt to save the lower lobe. Now, if you just plan on a pneumonectomy, I don't think you have to go intrapericardially for this. It looks like you could do a simple left pneumonectomy. However, if you want to inspect the pulmonary artery distally and see if you can get a big enough vessel to reattach to the main PA, then it would be a good idea to place a tourniquet proximal, closer to the right ventricle, proximal to the ductus arteriosus, so it doesn't slip at the time.
Go ahead, Ricardo.
Yeah. I was trying to hear what she was saying. So we were planning surgery, of course. We were trying to perform a left upper lobe. I also agree with Abbas. I'm also now better with robotic than even open for some cases. I believe we have a better vision and a better possibility of dissecting some structures with the robotic platform. Unfortunately, we have an SI in this hospital. This is in the public hospital. We have XI in the private one. In this case, we always do 3D planning. Always no, but in many cases we do 3D planning, and it can help us to plan the procedure. And in this case, we use 3D slicer. We also use Synapse as an alternative. And what we saw, it was in green, we see the lymph nodes. In yellow, the mass. Blue is the pulmonary artery. Red, the vein. And in light blue, we see the bronchus. And then we can define where are the critical steps. Of course, this is possible to do with the CT scan, as we were looking at it some minutes ago. But I think when we do the 3D planning, we can reconstruct in our minds better and remove some structures to understand better where the critical points are. So when we remove the vein, we see the artery. The vein didn't look like involved with a tumor. Neither was the bronchus. And then we see that the artery had two different points of contact. The lymph node was over the pulmonary artery, the main PA, just when it leaves the pericardium. And the mass was involving the first part of the PA just after the first branch, as we see the first branch here, and this branch. What we saw was that if we were able to remove the lymph node, we would have a good space here to apply a tourniquet if it was necessary, or to dissect the pulmonary artery. And then the critical point would be exactly the space between the first branch and this second branch. And the second branch was apparently really involved and encased by the artery, by the tumor, whereas the artery itself didn't look really encased by the tumor, as we see a good space here. And so our impression was that it would be possible to just perform a lateral arterioplasty here. That was what the 3D planning added for us in terms of planning the surgery itself. This is the video of the surgery. We have here some, well, we repeat the planning. I'm sorry, this is a little bit long. Planning, no, oh, no, here. So this is the surgical video of the procedure. There is some planning here. We use the forearm platform, the forearm technique. I use the camera in this second part. Many times I use the camera, and most of the times actually I use the camera in this portal, more posterior. It is different from many surgeons. I prefer the posterior dissection, and so it is better for me when the camera is in this portal number 2. And in this case, we planned also a small auxiliary incision for the tourniquet. So we didn't open it at the beginning, but then you see that when we decided to use the tourniquet, and then we exteriorized the tourniquet through a small incision in the 4th space. So this was the setup for this case. Oh, sorry. So we started, as we always start, with a pulmonary ligament. We always use the bipolar and the carrier. When I use the XI, I use the tip-up in the 4th arm. Here I used another carrier. And after that, we dissected the pulmonary vein, the posterior mediastinum. I always dissect here the vagus nerve, and then dissect the lymph nodes in the subcarinal situation. After that, we moved to the fissure. And as we see here, the fissure was not really, it wasn't a transfissural invasion. There wasn't a transfissural invasion. And we could locate the pulmonary artery, at least the anterior part of it, in its interlobar position. We removed the lymph node between the lingular artery and the basilar artery here. As you see, it was possible to identify it very well. And the tumor, the challenging part was just behind us. So it was possible to identify very well the tumor. And then we were opening the anterior part of the fissure. To open the anterior part, we always dissect that space between the 2 veins, the inferior vein and the superior vein. This triangle here is where you find the 11 lymph node, as you see here. And this is a very good strategy to open, as you see here, to open the anterior fissure. And this is a very good space to open the anterior fissure, as you see here. And then we have a better access to the pulmonary artery. And the bronchus is very visible now. We have the basilar artery here, the lingular artery here. And then after having this ready for, well, for what we were supposed to do later, we went to the more challenging part, the lymph nodes 5 and 6. we were able to dissect the lymph nodes. Here we first released the vein, then the artery. Unfortunately, we had to sacrifice the recurrent nerve. It was involved totally by the lymph node, even though she wasn't really hoarse when we first saw her. But that was an incredible thing, because after the surgery, even though we cut it, and we have no doubt, she was hoarse for the first 2 weeks, and then she recovered totally her voice. And so we see that the artery was now really visible as we expected, according to what we have planned in our 3D reconstruction. So the upper vein was now ligated, stapled. We had a better access of the pulmonary artery, and we decided to ligate everything we could. So then the lingular artery, and then here is the difficult point. We see the artery, the main artery here, the bronchus, and the bronchus was quite easy to dissect. As you see, in this part now, I'm passing the carrier behind the bronchus without any difficulty. And so we stapled the bronchus, and then the tumor was only there due to the artery. Here, I decided that it wasn't possible to really, let me just stop here for a minute. It wasn't really possible to dissect more, because this branch and this branch were totally involved by the tumor, and we also had to have good margins. And then in this moment, we were discussing if you would like do put like a stapler here, but then the artery would be too narrow. Probably it wasn't possible to apply a stapler safely here. And then we decided to put the tourniquet in this part of the artery. As you see, it is very well dissected, and so wasn't really difficult to do it. And tourniquets in this other two branches of the artery. And so the tourniquet is exteriorized by that incision in the fourth space. I must confess that this is a little bit stressing in this part of the procedure, because when you open the artery, you don't have as much as that sense of control, you know, when you have it open. Of course, this is not me applying this. This is one of my assistants. And then after having the artery controlled, we dissected a little bit more. Just go. And then it was possible to dissect a little bit more. And then we opened the artery, and then let me just here. We opened the artery. We later sent this part of the artery to frozen section. It was negative.
Did you get distal control?
Yes. We have here. Let me just get back. You can see here, Abbas, distal control.
Yes.
Here, proximal control, distal
Yes.
control. We put 2 tourniquets in each of the branches, the basilar and the segment 6 here.
Yes. Beautiful.
And then we open the artery. This is the final hole. You have the sensation it won't close, but then it closes very well. I used a PDA Prolin 50. It is quite challenging to use such a suture with the robot, because if you the last part, if you touch the, let me just get back a little bit. If you grabs the suture, it tends to break. It's a little bit tricky. You have to avoid, you know, grabbing too much the suture itself. The suture is not particularly difficult. I think the most stressing part is the control.
So this is a primary repair.
Primary repair. So it was possible for us to open and take like a hole. It wasn't necessary to do a sleeve. That was our second option. When we sent to the frozen section and the margins were negative, we decided to do a primary repair. And now we released the distal control. We allowed some blood to have a flow back to the artery. You see some blood, and then we finished tying the knot. We allowed the air to come out. Oh, I forgot to say, but we use heparin when we 5 minutes before closing the artery.
How much?
5,000 units. And then we are cutting the sutures. This is the final repair.
Beautiful. Beautiful repair. Impressive.
Yes.
I agree.
You know, Ricardo, this is really great. Yes. I'm impressed, actually. I think the most important view is that last one after completing the repair. The artery is not stenosed. Yes. I was wondering if you should patch these, and it's obvious you have such a nice confirmation. I think this looks great, but how did you make that decision to patch or not to patch? You don't really know how exactly it will look like at the end.
That's totally right. My impression when I cut the artery and then I was approaching, you know, there is a part of it and you see me testing it. Let me just check here. We spent some time, we invested some time, you know, doing this, right? To check. As you have this magnified view, I must say that I was quite sure that it wouldn't be necessary to patch it, but of course I was a little bit stressed that it would be good at the end.
But it looks beautiful.
Totally sure. But then I didn't cut the tourniquet until I was really, you know, sure that the suture was good, because the other option would also be to perform a total double sleeve, right?
Yes.
But it wasn't necessary. And then we were also waiting the frozen sections, but it was good.
Ricardo, what's your experience with robotic arterioplasty and arterial sleeves?
You know, I don't have that much experience. I must confess that I have, I think, 2 or 3 cases. Bronchial sleeves, I have many. You know, I think this is quite common. But arterial sleeves, I think I don't have that many, unfortunately, or not. I don't know.
No, this is a beautiful approach, and you know, I think we should kind of think about how to advise surgeons in this situation. I think the planning you put into it preoperatively, the thinking it through, was really important. It gave you some confidence that you might be able to get away with this. I think I love how it looks. The tourniquets you're using are a little longer than I use. You know, we have these shorter tourniquets that you can apply inside and just leave them. And I usually don't leave them long hanging out. I've only, like yourself, only done a few of these, but I use shorter tourniquets. And then I have these laparoscopic bulldogs. I don't know if you've seen them, that are actually quite long, and you can actually double place the bulldog on top of the tourniquet, and this way the surgeon can have control on that tourniquet, and you can apply it as well as you want, rather than having your bedside surgeon apply the tourniquet for you. Because I agree with you, that to me also is very stressful.
Yeah, I tried to use the bulldog 2 times, but I must confess that I wasn't really, I don't think they were safe in my hands, at least, because when you apply it, you have to grab I think it has like a sort of learning curve to use it. And it wasn't really easy to apply. So I opted to use the tourniquet. I felt more safe, but I opted to use the tourniquet, exiting through the 4th space incision, because then I would have the control to open it and close it. My assistant would be able to do that.
Sure.
And so that was the way I thought, my reasoning about this. But I saw many people using this, but some people using the shorter one. I'm not sure what is your thinking about this.
That's what I think. It just allows the surgeon maybe to have control of that tourniquet rather than the bedside surgeon. But if you have, I'm sure you had a very qualified surgeon at the bedside that you trusted. What was Plan B if the tourniquet broke or something while you were in the artery? Are there specific instruments that you have? I'm sure you talked to the room and had a plan for what to do. What would that plan be?
Well, that's a very good question. We thought about this a couple of times. We have those big clamps, scalene clamps for vascular clamps. And so my assistant would apply it in the artery. I know that it would be certainly very stressful if that happened, but that would be Plan B. We already had, some space for opening the pericardium and apply it intrapericardially if something bad happened. So that would be the approach.
And that was my other question, Ricardo. I agree. Yes, I have those longer scalene vascular clamps, which are really good to apply thoracoscopically and can get to where you need it. You did not open the pericardium, though. On the left side, you have a beautiful dissection. You can see how, you're able to pass the tourniquet extrapericardially here. But sometimes on the left side, especially, the artery is short before it gives off the first branch. Should you have opened the pericardium?
Yes, that's also a very good question. This is what I expected, actually, this view from the reconstruction, the 3D reconstruction. My impression was that if I was taking out the lymph node, I would have a very good space in this artery. It was longer than usual. If it was shorter, I would probably open the pericardium. The only thing is that if I was putting the tourniquet, and you have the pulmonary ligament, and if the arteriosum ligament, ductus, yes, the ductus. If I was using it before the ductus, the dissection is a little bit difficult when you try to pass it's more difficult actually when you try to pass behind the artery, So, but that would be certainly the option if I was there and the artery was too short.
So that's the point I think Diego Rivas makes about where to place the tourniquet on a left-sided sleeve. And I tend to agree with you also that it's a little more difficult to get proximal to the ligamentum arteriosum, but it helps to hold the tourniquet in place so it doesn't slide.
Yes.
And I agree with him also about that. So whenever possible, I think that's the better place for the tourniquet because it just holds there. It's held between the main PA and the ligamentum.
I think one trick there, can you hear me?
Yes.
Okay. I think one trick in the planning, phase of the surgery is when you have the main problem or invasion in the pulmonary artery, and it's from the first branch forward, and then you are able to use a tourniquet extrapericardial. You have enough space. The problem is when is involving totally the first branch and have, more invasion, and you have to do a little bit more proximally. I think this is my boundary,
Yes. Well,
how I see
I think you mentioned it, but one thing you did was a very nice extirpation of the AP window. I think that's why it looks so ready. The way you have it is you removed the nerve that was attached to it, and you didn't hesitate to really get a good dissection in that area. So I think that's a lesson, is before you kind of proceed too much, get that station 5 AP area dissected out. Very nice.
So the final pathology showed an atypical carcinoid tumor, as we would expect for this big tumor. Margins free. Lymph nodes, we had 5 and 6 positive. All the others were negative. She was discharged from the ICU in the first postoperative day. We usually don't send patients to ICU. This specific patient we decided to send because we were a little bit concerned about, I don't know. And the chest tube was removed on the 3rd day, and she was discharged in the 3rd day. This is her postoperative X-ray. So, and my final question is if someone would give some adjuvant therapy for this patient. We have already discussed that in Luis' case last week, but last meeting. But I'd like to hear from you. Just do something else.
Well, first of all, bravo, and thank you so much for bringing this case, Ricardo. Really amazing. It shows us that there are no boundaries, that we can really take patient care to any degree as long as we understand and plan and prepare for our patients. I think we touched on this. Is there any role for adjuvant chemotherapy in atypical carcinoid? It was not neuroendocrine carcinoma by definition. It was more atypical carcinoid with some necrosis present and high mitotic race. Is that correct?
Yes.
It was not a large cell. So
no.
She is already cured by you.
Yeah.
It was such an excellent dissection, I am impressed with your surgery, Ricardo. Very nice, and the patient by now is cured. I don't think there is no other or different option in adjuvant therapy for this patient, and of course she has chances of long-term metastasis. By now you have nothing else to do. You've done it.
Thanks, Luis.
I agree. It's not that she. Yes, I agree with Luis. It's not that she can't have a recurrence. It's that we don't have any agents that are effective for atypical carcinoid. There's no evidence, in my opinion.
No, there's no evidence. We review that topic extensively, and really there is no good level of evidence in adjuvancy in a typical carcinoid, and none in typical, of course.
Now, of course, you might find an oncologist who will do it. And I wonder, Ricardo, are you going to give her adjuvant therapy?
No, we have discussed that in our multidisciplinary board, and medical oncologists were quite concerned about recurrence, but at the end, the decision was to not give anything else.
Beautiful case.
No, she has a like 40% chance of recurrence, but because it's an atypical with node positives, but even with that, there is for now, nothing else to do.
Yeah.
Yeah,
watch
for
her
now
carefully.
is the answer. I'm sorry, I interrupted.
No, go ahead, Adrian.
Yes, I was thinking, Dr. Terra, again, congratulations and lucky patient. And I guess you will have to be so accurate with the following of this patient with the PET-CT with gallium, and just follow the case. But by now, don't do anything else in terms of adjuvant therapy.
That's a great point, Dr. Serna. Did you get a gallium scan pre-op, and how are you going to follow this patient? A PET, a net spot.
Yeah, we don't, unfortunately, in our public hospital, we don't have access to the gallium scan, and it's like very irregular, the availability of the exam, and so we didn't have it beforehand. So it was a FDG PET scan, and so I'm not sure we will be able to follow her with a gallium.
Right, because you don't have a baseline, but at least you know that it was FDG avid. So
yes,
in the future, yeah.
For these patients that already showed that the FDG uptake was high, that it could be a very good for follow-up, and at least have a baseline right now of chromogranin A serum levels.
Oh yeah,
yeah,
that's a good point. Yeah,
that's a great point.
That's a good point. So I think we'll follow her with the PET scan, and I think the chromogranin, I didn't think about that. I think it's interesting.
To have a baseline right now, just that for.
Yes. Yes, I think we have one before the procedure. I think that someone ordered it. So that's a good point.
Any other comments or questions to Dr. Ricardo Terra?
Very nice case. Impressive. Very nice.
Yes, now we have big shoes to fill. So thank you so much again, Ricardo, and please, do your best to join us every month. We'll be presenting our difficult cases or our interesting cases, or just getting together and talking about thoracic surgery. If anyone has a case they would like to present, please reach out to Facundo Iriarte, our director. And until then, thank you so much, and have a great day.
Thank you. And it was a great opportunity to present the case. Thank you everyone for the comments. Just like to make a promotion, we have our International Congress next week. It's a International Robotic Surgery Congress. So if you're able to connect, it is online. You are all invited.
What day?
It is 15 to 17 June. Actually, 15 is the pre-Congress, and 16 and 17 we'll have the meeting itself. Mark Deliuski will participate. He will have a live case.
That's right, yeah.
Yeah, Jens Rucker.
You know, ISMIX is at the same time in Warsaw. And
Yeah.
yes, so you're not coming to ISMIX, I guess, but
Unfortunately not. But I'm going to SRS.
yes, good. I'll
Orlando.
see you there.
Great, great.
Congratulations and good luck with your meeting, Ricardo.
Thank you so much, guys. Thank you so much. It was a great meeting.
Bye-bye.
Thank you, everyone.
Gracias, Facundo.
Right.
Gracias a
Time
ustedes.
out. We have Mr.
Hi, thank you so much.